It's such a pleasure to be here. We've known about the society for probably 10 years. Working with some lawyers in Madagascar as we were registering our work, they told us about the society. And for whatever reason, over the years, it's been hard to coordinate. But so we're really excited to be here and to talk about our work and about Madagascar.
Yeah, absolutely. It's so nice to be here, and I can't believe how many delightful people I've already met. I was saying I was a little, it's always a little nerve-wracking when you're about to speak in front of a group, and now I just feel at home. Before we get started, I do want to say that whilst you're seeing Seth and myself here, we do have an amazing team of people in Madagascar who I wish we could just snap our fingers and bring over here. So these are the brilliant, fabulous women who are leading our organisation in Madagascar, and I wish they could be here. They sent us these photos before today, and this was their, very kind of like, we're going to be really professional, and you can see they're just melted down pretty quickly. They have a lot of fun together and really enjoy each other's company, and they bring that joy and compassion into the work that they do with the beneficiaries that we serve and the women on the ground, which, if you know anything about fistula, is somewhat extraordinary. Fistula is just an absolutely dreadful aberration that shouldn't exist anymore in the world that we're in, and yet it does for more than 1 million women. Can I just see by sort of show of hands, how many people have heard of obstetric fistula in this room? Okay, wow. That's pretty extraordinary. It means we're in a really educated audience, which is wonderful. We describe obstetric fistula in the communities that we work in as the worst thing you've never heard of, because there's huge amounts of misunderstanding about the injury, and the majority of women who live with this injury don't know that they have it. They think they've been cursed, they think that they have been, punished. It's awful, and so there's a huge amount of public education that we need to do in our work. So this woman on the screen we're going to call her Francine. That's not her name because we're going to protect her privacy. But when we talk about our work, I think the most powerful way to really communicate it is to talk about the journey of a patient. So this is Francine. Her life was devastated by the loss of her baby. She was 15 years old when she experienced a prolonged labour over 4 days, and she waited for a C-section that would never come. And over the course of that 4 days, her baby died. Following that incredibly traumatic loss, she woke up the next day soaking wet. She thought maybe she'd had an accident, but as she continued through the day, the leaking just wouldn't stop. This went on, and eventually her husband, who was 35, lost patience and kicked her out of the house. So Francine's 15 years old, she's experienced stillbirth, and she's constantly leaking urine, so she smells. So she goes to her parents, she asks them to take her in, and they also reject her. Francine lives like this for 10 years. Total isolation. People from the community won't speak to her. She can't go to the market. And, as I said at the beginning, she has no idea that she's living with an injury that can be fixed. So she's living with obstetric fistula. So this is what it means literally. And I was saying to Chris, one of the things that is challenging about our work is this word, fistula. It's a very clinical word that doesn't necessarily speak to that human experience. So this is obstetric fistula. And I'm going to talk a little bit more about a broader view of the injury, not just Francine's story now. So the injury happens when you go into labour and the labour can't progress. So the baby becomes trapped in the birth canal. This can happen and go on for days and days and days. If your pelvis is insufficiently broad enough to bear a child, then the baby just gets stuck. So this can go on for multiple days. And in countries where health systems don't work, or where women in very isolated environments are too far away from health system environments where they could go for help with assisted delivery or to get access to a C-section, they experience fistula. Their baby dies, and the skin that is inside the birth canal, because of the pressure of the baby's head, it dies. And it creates a hole between your vagina and your bladder or your rectum, and then you leak constantly. There's nothing that can be done about it, and you just live with the sort of stigma of the odour, and it destroys your life. So you're living with the trauma of losing your child, you're living with this odour that makes you sort of anathema to your community. And as I said, it affects 1 million women in the world. In Madagascar, the government estimates that there are 50,000 women living with fistula at the moment. Francine's story involves this man. So this is Dr. Fidel Rakoto Arivalolana. He operates in the Sava region. When we met him, he had done 63 fistula repairs over the course of his 30-year career. So this is a surgery that was developed in 1850. That's why we don't have any fistula really in the global north. There are women who get the injury, but usually they don't even realise it's happened. They're going to get the repair right there in the delivery room or in the days following. It's kind of an immediate fix, right? But if you're in a low middle income country that doesn't have that kind of health system, then you're not going to have that experience. So there are people like Dr. Fidel, and those 63 women that he treated in his 30-year career, it's about 2 per year, he mostly funded that treatment out of his own pocket. And that's because fistula is hugely neglected and because it's very difficult for local surgeons to access funding. So when we met Dr. Fidel and onboarded him into our program, which I'll have Seth speak to you about in a minute, he treated 75 women in the first year that we supported him. So if you think about that growth in throughput, that means, he was able to help, 3 times the number of women as he'd been able to help in the previous 3 decades. So it's an extraordinary increase in impact. A fundamental aspect of our model is that we believe that it's people like Dr. Fidel, the people who are closest to the problem, who are on the ground, who should be empowered to solve the problem. So that's what we do. So here's Dr. Fidel. And I'm going to hand over to Seth now to speak to you a little bit more about our funding model and how it works, and also about what you're seeing here with Dr. Fidel. So it's the right-hand clicker. It's the right-hand.
I've not used, this is new.
This is new. I just got it yesterday.
So you can see it's a devastating injury. It also used to happen here a lot. And in Madagascar and in most other places where it occurs, it is particularly devastating because it ruins not only the individual's life, but the family. The women may have other children. And it isolates them from their communities. I mean, those of you who everyone here has spent some time in Madagascar, you know how critical the community is to the individual. It's a huge part of who they are. And this strips them from that. And when that's one of the reasons I started the organization, was because I prior worked in private equity, and I had resources, and I wanted to put them to work philanthropically, and I thought, what is the thing that I can do that has the most concrete impact on human lives? And this issue is, I believe it's the most addressable injustice that exists, and it shouldn't happen, but it does. It's completely correctable from a surgery that's almost 150 years old, costs very little, but virtually no woman who has this actually gets treated. And so when I quit my wealth management life to go into the field, I went and spoke with people who were doing this work, because what do I know? I mean, nothing really, right? So talking to people like Fidel about what can we do to help? How can we help, right? And all of these people said, across the board, really it's about resources. We cannot, as a Malagasy surgeon, as an African surgeon, we cannot access resources from these countries that donate because we don't have accountants to do the reports that are required for those grants. So if you give money as donors, give money to Oxfam or a big charity, what tends to happen is they pool that money and then they make grants to organizations, typically, in these countries. And those grants are very restricted. They're very controlled. And you have to report. You have to have accountants to report on this. And these surgeons are operating in Ministry of Health. They're operating in public health systems. They don't have those resources. They don't have those human resources. So they're cut off from the money. And so what they said, well, if we could just even get small money, we could do really great work. And so we thought about how could we change the way philanthropy works with this issue. And instead of giving grants and controlling how it's spent, we could change the way the money flows so that we gave contracts to surgeons who were qualified, who we had recommendations, and we could make the money flow when they did the work that we cared about, right? So we don't care how they spend the money, except for how the countries where we're founded in require it. No politics, religion, or terrorism, right? These are things we're obliged to by law. But otherwise, they can spend the money on motivating staff to come, on medicines, on patient mobilization. They can put the money in their own pockets. It doesn't matter to us. What matters is that the patients don't pay and that they get high quality care. And so we took they gave us this idea, and we structured it in a way that would work with philanthropists in the United States, where I'm from, and here in England. And so the way our model works is kind of like an insurance program. Okay, so we have qualified surgeons who we know are qualified by recommendations. We then give those qualified surgeons contracts that give a cost per patient that we'll reimburse, and they give a number of patients. And then as they treat the patients, they take a little phone or a tablet. And this has got a little blue case around it, so like you'd have for your kids or your grandkids, if they drop it doesn't break. And as they treat patients, they enter that data comes up into the cloud, and our team. It used to be here, but it's also now mostly in Madagascar. Even for the whole world, it's in Madagascar. We've centered a lot of our team there, as Helen said. It gets validated, and as it's validated, they're paid monthly. Those grants are issued monthly. They're unrestricted. It's very much appreciated, as you can imagine, because they have not huge money, but enough to mobilize the rest of their work. And so we basically provided that money. That's how Helen was saying. This guy went from 63 over 30 years to 75 in a year. And we did that not only with volume, but we really drastically improved quality. Because when you have data overseeing the work, you can redirect the activity. And we can talk more about that. I don't want to geek out a little too much on that, but it's really important to us, right? And so, interestingly, okay, fistula happens to be one of those issues that has multiple causes. Most directly, it's you didn't have access to a C-section. But there's other factors. There's sometimes a woman does get to a hospital and gets an injury from the surgery, something we would say iatrogenic, like a mistake in the hospital. Sometimes it happens that they're very young when they get pregnant, which is gender-based violence. Impregnating a 15-year-old girl or younger is a real problem in the system. And when we have this data, we're able to, we have a competency in visualizing this data, and we are able to then use that to inform the government about how the system is not working. So we take this little issue and we make it a much broader sort of map of how the systems are failing women and girls. So there's a lot, as you can imagine, there's a lot of impact surrounding this tiny little stream of money that goes directly to the people doing the work. So in the case of Francine, her story is not unique. It's pretty broad spaced. When she comes to get the treatment for free, and she realizes that she's not alone having this injury, she builds an immediate community with the other patients who have this, and they share stories amongst themselves and become somewhat of a support group. Just realizing you're not alone in it. And then most of them have a really positive surgical outcomes. As a result, they stop leaking. The surgery is a pretty simple surgery, unless it's super complicated. So it's one of those, it's easy until it's not, and the not is a pretty small number. She went on to become like an entrepreneur, like a lot of the women in these rural places are. She started buying first chickens and selling the eggs. And then she parlayed that into buying hotels, not what you would think of as a hotel, but little shacks that she would use as like shelters. And she's done very well. I mean, she's consistently improved her life. And like I said, this is why it's such a high impact thing. You take somebody who's on the verge of death, and you help them recover their dignity and their power, and then because they've survived this adversity, they fly. You know, they have really a lot of power. So, our as an organization, our vision is to end fistula for every woman everywhere. And during the pandemic, this particular funding model, we do a lot more in Madagascar than just this funding model, and we're going to tell you a little bit more about that. But this particular funding model was in high demand. Okay, we had the government of Madagascar asked us to expand. We were working just in 2 regions, in Sava and Batavave-Fitfanan, which has now been split into 2 regions. And the government asked us to take this funding model national, all across Madagascar. And we did, in 2020, we did that. And the demand was so great from Madagascar, we also believed there was greater demand outside Madagascar, so we opened it up to other countries. And within months, we expanded to 17 other countries, where we worked in partnership with government and with the UN to bring this small money to many of these surgeons and use that data to inform the systems. But in Madagascar, we've done more. We've done a lot more. So,
yeah. Just one little extra detail about Francine. So, do you remember I said she lived with this for 10 years? So the surgery she had that fixed her injury took 45 minutes. So just as like a nugget of information, you know, there are certain things we really want you to take away with you today. That's one of them, right? This woman lived with this injury for 10 years, and we treat women who've had it for way longer than that, needlessly suffering this awful life. And a surgeon like Fidel did treat it in, you know, less than an hour. So just at this point, before I talk to you, I'm going to talk to you about our work and our programs and how everything actually works in a minute. But just at this stage, just take away that, you know, fistula is this really important issue. Right? The suffering is huge and nobody knows about it. So if we can create, I counted, I think there's about 40 people in this room, if we can create that many advocates today, that's huge. It's solvable, just like Seth said, right? Seth changed his entire life because he discovered this issue and said, I'm going to end this injustice in my lifetime, right? This is a solvable public health issue. These are rare. These are rare things that we can actually end in our lifetime. And it's neglected, right? There's 1 million women living with the injury. And, you know, to be honest, the data that we have globally on this is so poor. These women live in hugely isolated communities. So I think there's probably more than 1 million, certainly after the pandemic. And if you're following global news, you'll know that investment in women and girls is just collapsing. So if you can keep those 3 things in your head, if that's all you remember today, then we've done our job.
Can I just add, there's one thing that we say a lot about this, about the neglected nature of this very small but very important issue, that it's big enough to matter and small enough to end.
Yeah.
Okay, like there's so many things that we really can't do anything tangible about, but this one we can, and the amount of money to end it, to treat every woman who has it, it's not that much money on the global scheme of things, not even for any other cause. So it's something where mobilizing money and doing that in cooperation with the governments where it exists, and we'll talk about that more, can really end suffering that is immense, okay, and inform how the system can prevent other issues from occurring.
Yeah, absolutely. So this is the program we've mostly been speaking about so far, right? Fistula Care funding. This is the innovative funding model that we've created that's data-driven, that's led by those closest to the problem, that involves empowering them with the funding that's going to unlock their ability to do the work that they already know how to do, but they just don't have the resources to deliver. So this just sort of summarizes a little bit about what we've already told you, but you know, we have this funding model. We started it in Madagascar. We grew it there very quickly with the government during the pandemic. And then we knew from our colleagues around the world that fistula funding was, again, during the pandemic, getting reprioritized to address COVID. So we stepped up and we said, okay, if your funding's gone away because of strategic changes or global circumstances or whatever is happening in your facility, contact us. We'll figure out a way to help you. And that's how our model, this funding model, grew to 17 countries over 12 months. These are 12 months when Seth and I were not seeing each other, we were camped out in our isolation, and it was incredible to be talking to 69 surgeons in 17 countries about all this work that they were doing during that time. So in that period of time, over that period, we've treated over 4,500 women. In 2018, when I joined the organisation, we treated 44 women. So as an organisation, we've really figured out how to do this, how to do it well, and we've scaled that impact to women in need.
And another footnote, sorry.
Sorry. We said we were going to do this, we're doing a dance.
We're doing jazz. So in this time when Helen started, we had 9 staff in South London, okay, and no staff in Madagascar. And now we got to the point where we had, I think, 150 staff in Madagascar, because we were, as we're going to show you these other, whenever a charity, we have different programs, different verticals that we do, and we're going to talk to you about those. But we had a bunch of money from the government of Canada to experiment with a bunch of stuff in Madagascar, because it's a laboratory for us. And in that, we engaged a lot of professional Malagasys, and we realized that they were really well positioned to grow the organization globally. So as roles were vacated here, we hired positions in Madagascar. Now the organization is principally Malagasy, and you saw a small group of the leaders of the organization, but it is very much led by we have two staff in England, 3, sorry,
3, yeah.
Me. And the rest is Madagascar. So that's like a big shift. That's a big shift for an organization.
Just a little bit about kind of what we have for our horizon here for the next sort of strategic period, which is as a result of our success and our swift growth, we've been able to work with big partners, those huge multilateral agencies that have billions of dollars, to build global partnership agreements. So we have a global partnership agreement with UNFPA, which is the UN's division that does population health and sexual and reproductive health and rights. And we're planning to scale the funding model to their 60 countries. So the UNFPA hosts the campaign to end fistula, which is kind of a global network consortium of people working on this. It's where we all connect with our partners, and we're working with them to try and scale our funding to those 60 countries and aiming to treat 15,000 women over the next 3 years. That last bullet looks small, but this model of funding is perfect for governments that can't figure out how to solve this problem, because they can plug it into their national system, and then we have the quality data management technical expertise to then be able to capacity build with them so they understand how they can do the quality management on the ground. So we're really prioritizing national integration with governments, because fistula is a development problem. We exist to end fistula, but we have to acknowledge that Seth and I aren't going to do that, right, by ourselves. The two of us are not going to end fistula for the million women around the world. Fistula has to be solved by the governments in the countries who control the health systems, who control the system, who can fix the system failure that's leading to these injuries. So that's a huge priority for us in the next strategic period. In Madagascar, we've had phenomenal support from the Ministry of Health, and also from the Ministry of Population, and we have an accord de siège with the government. And this is Dr. Yoel, former Minister of Health. He's just saying some nice things about how what they're doing has worked, which is always nice. So I wanted to share that with you all as well.
And it's a very long quote, but it was translated. So just like another footnote about the evolution of the organization, okay? The first place where we ever had a government kind of adopt this idea of giving funding directly to the staff of their Ministry of Health. That's like a pretty revolutionary thing, right? To pay doctors in a health system to do work that it's mandated, but it's not their day-to-day job. It was Madagascar government that identified this idea, and they made, and I can tell you, we probably don't have time, I can tell you, if anybody's interested in that story, I can tell you what happened, because it was crazy. We got elevated out of nowhere and put up in front of, as an example for all the other development partners, is this is how we want to work. Because they had a fight with the World Bank about this. And so because of that, we've been close with multiple different ministries, which changed quite a bit as you've had the political changes in the country. But civil servants, some of them don't change, and they really support our work. So we have a really strong engagement with the government.
Absolutely. So this is a really critical aspect of our work in Madagascar, and in general is a major consideration for any fistula organisation and any woman with fistula, right? So not all women are like Francine. Francine lived with fistula. She learnt about our services. I missed this from her story. It's a little footnote. She learnt about our services from a radio advertisement that we put out. And then she walked for 3 days to get to the health facility in the radio ad to get treatment, right? So she sat and said, do you know what? I've had enough of this. I'm gonna go and I'm gonna see if this is real. I'm gonna see if I can get treated. But a lot of those women that I was describing, they don't know they have the injury. They don't understand what's happening. And they're living in these incredibly isolated rural environments. So actually finding these women is a massive problem that we have to solve. My colleague Gigi said, finding women with a fistula is like searching for a needle in an invisible haystack. Because where are they, right? So engagement is a huge part of our work. This involves radio advertising, a hotline, Facebook, any way that we can reach people, right, in a diffuse way, but it also involves those guys in that picture, right, boots on the ground, people going out into these communities on the ground to try and find women. So this was piloted across those 3 regions that Seth described, Sava, Vatovavy, and Fitvanam, and as a result we were able to identify more than 2,000 patients in Madagascar. And then it's a case of connecting those patients to referral networks that will then mobilise them and connect them to care. Now, we do that. We were doing that in Madagascar, but also in general, if you think about it as a global issue, that's a major challenge, right? Because if you're talking to a woman who lives far away from not just health facilities, but from the nearest road, getting her from there to a surgeon who can repair her is expensive, it takes a lot of time. You have a safeguarding responsibility to make sure that she's, gets sleep and food and is well cared for, while she's also living with these symptoms, right? So she's leaking, so you can't put her on a bus because the rest of the people on the bus don't want to sit next to someone who smells. So there's huge challenges around this, right? When you actually get into the grassroots of figuring it out. So that's what our team on the ground is doing. They're kind of working out how do we do that, and have done so very effectively. So in fact, our approach, the combination of that diffuse, like centralized communications with the grassroots on the ground communication and community embedding has resulted in our, being requested to partner with organisations in other countries. So we have a partnership with Tostan. Do any of you know Tostan by a raise of hands? So they're working on FGM, female genital cutting or female genital mutilation. And we're actually replicating that with them in 2 regions of Senegal. So that approach to just community outreach and reaching women with the injury. So in the next strategic phase, we're hoping to expand to nationally across Madagascar to get to all 23 regions. And also, as Seth was saying, our team in Madagascar is uniquely situated to build what we call south-to-south collaboration. So reaching out to people and community organisations in other countries in the global south and saying, we have this proven model that works, let us help you replicate it so that you can do that work, right? So that you can help these women.
One thing that sort of the more detail behind this idea, right, is if there's a couple things maybe you'll take from this. One is we are a super data-driven organization. It's like data, it takes away a lot of the things that politics or emotion might have. You just have the data can clarify or can confirm stuff. That's one. The other is proximity is power. Yeah. We really believe that people closest to the issues have the best ideas. Okay, so when we got this money from Canada, what we did is we hired a management team, and we told that management team broadly what we wanted to do. So we want to find every patient in 50 communes. The communes are the subdivision of districts. And then we kind of let them figure out how. We didn't tell them how, this is also pretty different than how international development works. We told them what, and we let them figure out how. Okay, and they did a couple things. And we're going to show you this. One of the things they said is we need to map. We need to know where the people are to know where the problem is. Because you can look on your phone and you can find out where every restaurants and where everything is, where every address is. You have postcodes. We don't have that in Madagascar. There's massive parts of the country that have never been mapped, where people live and nobody even knows. And we're going to show you how we've evolved that. But we've also had them, they came up with a couple different ways to put people in the villages and to go out talk to leaders of religious or political groups and people within the health system. Is very clever. But they also said, well, we should also we should buy district radio ads. Okay, so instead of giving a script to a radio company and say we want you to do this ad, centrally driven sort of marketing, they said, kind of like we said to them, here's kind of what we want to get at. You figure out how. And these district radio groups would put out these really interesting, I mean, they were really different. We would listen, we didn't know, we don't speak Malagasy here, but they were all over the map, okay? When we got the data after the fact, we found out that they were so much more effective than the people were because they raised awareness on a level where people were self-referring. So I think we'll talk about that in some of the slides.
We will.
Yeah, sorry, I'm getting
No, it's good. So, do you remember how I said my colleague Gigi says, finding a woman with fistula is like searching for a needle in an invisible haystack? So in 2011, that's how much of Madagascar was mapped.
Mapped in OpenStreetMaps. OpenStreetMaps is an open source mapping tool that is used by Apple. So if you use your Apple Maps, that accesses OpenStreetMaps. So
that's what those pink dots, right, means that you could zoom into those places and you'd be able to be on a street and say, I want to find this address, and you could do that using the map.
And these are the two regions marked out where we've worked in the initial stages of our work.
So what you're going to see is, our local team started mapping in 2019. So I'm going to hit play on this, and what you'll see happen to this map is this blossoming of mapping that happens between 2019 and 2021.
Yeah, 2013. It's by month. And this doesn't even show the quality of mapping, which is, ours was very high. Malagasy Lab, Malagasy Conceived. So watch now, watch our key regions.
Here it comes. That's our mapping team. So that's a group of people in Madagascar sitting on their computers, literally drawing. I mean, Seth, I have to be careful with Seth here, because if I let him talk about this, he'll take the rest of the presentation. We used to do it also, the Madagascar team got us excited about it, and they were like, well, you could do it when you're on webinars. You just open it up and you can zoom into a place, and you'll see, okay, well, houses are these, so you draw a box and you mark it and say this is a house, or you see a river and you mark it and you say this is a river, or you see a footpath, and it's extraordinary to realise that if you think about that, the amount of information that's been added to that map, that's all been done by Operation Fistula, and in fact, we are the largest mapper of Madagascar. To date. We've done more, so that's more than 56,000 square kilometres.
Our little team of 5 Malagasy mappers mapped more of Madagascar in 2 years than had been mapped by every other mapper ever. Okay? And if you look, you guys know the country, you know where the people live. Look how much better mapped Natawavi and Sava are than Tana. It's remarkable.
And we use mapping in everything. I don't know if you noticed that image with the dashboard with Fidel with the dots on the map. It's everything that we do is geolocated, geospecific. So
this was, I know we don't want to take too much time, so we'll go through this quickly. But this gives you a sense of, we had boots on the ground going to villages. That was really, we did thousands and thousands, right? We had home visits, we had group discussions, we'd get people together and talk. We had sensitizations, or that's the French version of it, which is we go and we have somebody talk to a group of people about the issue. Community meetings, we have different types of community meetings. We have at the commune, at the Fokatani, everywhere. We put a lot of money into getting people to go. And the crazy thing is that, and actually in this next thing, this is a little techno geek, so forgive us. But this is Sava, and this is by commune, okay? And you can see this. This is where we had events, meetings, and the darker it is, this one we had 130 meetings, okay? This is where we found patients, the darker, the more patients, and this is the percentage of patients we found, the lighter, the more, right? So what we discovered, you can play the video, is that in places where we had a lot of meetings, let's see if I can click it, we didn't necessarily find the most patients, okay? In other places where we had fewer meetings, but more targeted, and we used the ads and the Facebook and all this, we found a lot more patients. So this made us kind of revisit our structure, and instead of having huge staff, which is expensive, we reverted to a smaller staff in Tana with the idea to go national and be more focused on using the district radio ads and the social media.
Another really important lesson that we learned as a result of being boots on the ground in the communities, and this is also represented in the data, right, is that if you send a lot of people out in the world talking about fistula with an Operation Fistula vest on, fistula, and you're a woman living with the injury, a lot of women with fistula hide their symptoms. They become incredibly adept at hiding their symptoms because they know that the social, economic, cultural stigma that's going to be attached to them if people know they have this injury is going to be huge. So we learned that actually we need a broader safe motherhood brand, right? We need to be going out and not necessarily sort of outing women with the condition. We want them to feel really safe to come to us and say, you know what, actually I need your help. So we are adapting our messaging all the time because of what we're seeing in the data to be able to create better messaging that's going to reach these women on the ground. Just a few more programs. So that community of surgeons, I know I mentioned 69 around the world. These surgeons are operating on their own in massive isolation, so they don't have access to sort of medical surgical conferences where they can chin wag with each other and talk about, how can I improve my, I had a surgeon the other day and the sutures I was using, weren't working really well on this kind of tissue, and what do you do about that? There's none of that cross-pollination between the community of fistula surgeons. So one of our programs is really let's build that globally. Let's build an environment where these surgeons can speak to each other about the issues that they're facing on the ground. So we have created a community of practice. It's mostly virtual. Again, so much of this came out of the pandemic when we were forced to say, well, what can we do without being there, right? We're just going to give people the tools that they need to be able to do their work. So we actually have a WhatsApp group with the surgeons across the 17 countries. They're talking to each other, they're engaging with each other, and our goal is to really grow that and create these really accessible, you can just send someone a WhatsApp message and you can get an answer to the question. So we have amazing real-time examples. One was about a woman who'd had a C-section who had a fistula, and the surgeon was saying, how long do you think I should wait until I do the repair? And the amazing, surgeons from 5 different countries are responding to this surgeon in Cameroon saying, actually I think you should do this, and best practice is this, or my experience when I've done something similar is this, and watch out for bleeding because, this is major. It's amazing. And this is all just happening in an environment that we're hosting.
Yeah, and again, Malagasy idea, everybody we work with has a phone. Yeah. So why don't we just let them talk to each other on WhatsApp? So we set up the groups and then they go.
And this is right, we have collected all of this data from all of these people all around the world, and it has huge capacity to move the dial when it comes to best practices and developing grassroots, locally led research. So that's another thing that we're doing with the community of practice is we're saying, let us work to support you to publish what you're finding through your own work. And because we're digitizing patient records and data, surgeons are able to, for the first time, see their results in aggregate form and see the insights for the first time, because the majority of surgeons operating in these countries are used to paper forms. There are rooms this big in hospitals that are just full of bags of paper, right? And so you can't necessarily say, well, I treated 25 women this year and I treated 35 last year. What were the comparisons? What did I learn from my own practice from a room of paper? But you can using the data that we've collected. And the other element that we're really prioritizing is developing a better measurement system for understanding our impact as an organization. So the majority of fistula organizations measure their impact by saying, we delivered, we've already done it, right? 4,500 fistula repairs in the last 3 years. But we need a measure that speaks to the experience of the women we're serving. What has been the qualitative impact on your life as a result of receiving the intervention? So we are in, right now, a research initiative that's being supported by Cleveland Hospital and by the government of Madagascar to create the first ever quality of life tool that will take qualitative feedback from patients, from interviews directly from them, and create a numerical way of coding that into data so that we can really understand what's been the experience. You have anything to add?
No.
So now I'm going to let Seth do the data stuff.
I'm the data geek, and I don't want to lose you guys. And I don't know how much.
Yeah, if you just put your hand up, or
We measure everything that matters, which is a lot of things. And the way this works is people have this phone, okay, like any phone will work, and there's we didn't build an app, we used existing stuff. And they basically enter data, even if they don't have internet, and it kind of works to hold it. And then when they do get to the internet, it uploads and it creates these data visualizations that goes back and tells them how they've been doing with their patients, like what do their trends look like, are they choosing the right difficulty or not, and then what for specific patients, what's happening, right? Because they do know the patients, but they don't know the aggregate, right? And so what we can do is by taking that individual patient data, we can zoom up or down and give information to the different stakeholders. For the surgeon, it helps them sort of identify trends, and then talk with a WhatsApp group. I'm seeing this, I'm seeing that. But it also lets us measure what's happening. So this is super internal for us, so I realize this might be a little too much data, but we can see, are the right levels of surgeon choosing the right cases? We can see what the trends look like every week. Is there something that's happening that we should know about? We can see if there's people are taking bigger risks or having more complications. And fundamentally, this allows us to then feed that information back to government. Because really, this exists because of government policy, right? If government policy had, focused on emergency obstetric care, this wouldn't be a problem, right? So because they're the source of the problem, they're also the solution. So, we've now recognized this through our work over the last couple of years, and we're really focusing our future on supporting the government to be more effective actor, and not just Madagascar, but many other countries as well. Maybe you want to talk about that?
So yeah, this is our big. These are our kind of big ideas for what's next. The vision, right, locked on the horizon of 2030. That's the deadline of the UN's Sustainable Development Goal agenda. We're not doing great, the world, at reaching those targets. The idea was that we'd have a gender equal world by 2030. I think we're nowhere near that, right? So we really are focused on doing as much as we possibly can before that deadline. And as Seth said, strengthening government initiatives is huge. That's got to be the priority. And we want to do that to the extent that we no longer exist, right? I mean, if we make it so that governments can solve this problem using the actors in the countries, using the systems in the countries, we disappear and both Seth and I go and get other jobs. We go fix something else. Expanding the reach of high-quality fistula care, that's so much about the data-driven model that we've already spoken about, using data to drive better policy. Sustainable funding, because we've got to make sure that we're able to exist and keep driving our work forward. And the last one is that we're starting to talk about what's next for the organisation, and we really want to elevate women into the leadership positions of the organisation. I'm sure you noticed our Madagascar team is entirely women, and Seth founded this organisation in 2008, and we're talking about how do we build this organisation into a future that's elevated by women and led by women. Chris, how are we doing for time?
Okay.
So we have a video that I'd love to show you that was shot and produced by our Madagascar team. It's about 8 minutes, and I want to make sure we have time for questions, but we can also send the video following. So I'm looking to you guys for guidance. Who do I need to make eyes at? Play the video? All right.
Before we play the video,
go ahead.
No, we have one more slide about climate change.
Oh yeah, I'm so sorry. Oh, this is really important actually.
This
Sorry.
is really important because everybody knows that if the climate doesn't support, it is the fundamental issue. We can't do the health until we can make sure the climate, people are reacting to the climate. Madagascar is particularly hit hard by climate change. In Batovavi, we had 2 successive cyclones that made every single one, and we had a big staff there, every single one of our staff homeless. BBC reported about this, said there was I think 90,000 people displaced. because we had data on every house, every elevation, and we knew where the hurricane or the cyclone had came. We estimated that more like 900,000 people displaced. And unfortunately, we couldn't get that out because Russia invaded Ukraine, so the news cycle got completely taken. This is a picture from when that happened, okay? And this is in Madagascar. This is a map of Madagascar deforestation, okay? These are 1,000-year-old trees. They're being cut down in national parks because there's a market in Asia for the trees. You can't sell them in Europe anymore. We are now increasingly aware of the effects of this on the populations we serve. We also think that there's ways to leverage the vulnerability of these markets to change some of this. Okay, so we're working on an idea right now that is about reforestation. Okay, that would have Fistula as a part of it, but principally this would be a private capital on the order of $50 to $200 million investment into Madagascar reforestation. And all the areas that are red here are areas that have lost forest in the last 10 years. So those are forests that have been cut down. And if I showed you the rest of the world, it's the only place that is darker is in the Central African Republic, where they're cutting trees out and carting them out in Cameroon, which I've seen for myself in eastern Cameroon. So this is a really, really big issue, okay, which I know everybody's aware of. And if anybody wants to talk about this too, I would love to talk to you about what we're thinking on that. So on to the video, if we have time.
Yeah, go for it. Thank you.
Hoeliky ny fianakaviana sy ny fiarahamonina miaina anaty enatra manafina ny toe-javatra iainana tsy fiainana mendrika ho an'ireo vehivavy ireo anefa izany afaka manampy azy isika
Nazahoako anazy zany dia fitirahana sarotra. Andro raika aloha ny etra zaza dia faharoany dia ndao amin'ny tombo-pahasalamana dia mididy. Didina zany ilay zaza vao noafaka satria efa potika taty ambanivolo. Mbola ray volana tagny satria tena sy nasary tegna mihitsy manko zany natongavako tagny. Dia sariko aby zany nangalandreo an'ilay zaza tao agnaty kibo. Dia nitazomin'ny dokotera eka zany satria trop be zany le aretigna anazy zany. Dia eo zany dia mbola sariko eo zany hoe mandeha pipi aho. Satria sady le raha misy fofony dia le raha koa zany sy afaka maigna tsara. Ary nanontany an'ilay dokotera misy aho tamin'ny fotoana zany satria mbola tapela tagnany teo. Hoe iaho dokotera sy masary temany. Dia nefa iaho taminay tagny dia masary tamany. Dia zany natonga anahy hoe ino ary ny zavatra mba nazahoako an'ity. Na firavavena hitanao rehefa manambady misy firavavy zany da mifankalaigna. Dia zany misy magnano ody rasy. Agny aby zany na mangano eritreritra anazy.
midina ny fotony izahay manantona ireo marary ary mihaino tsy mahafantatra bebe kokoa ny momba azy. Ary miara-dalàna feno aminy izahay ho totosa soamantsara ny fandidinana sitranana ilay aretiny.
Mamany lava vokatry ny fahasarotam-pitirahana dia mijanona ela be ao amin'ny lalan-jaza le lohan'ilay zaza dia rovotra ny tatavy dia mifandray ny tatavy sy n'ilay lalan-jaza. Izay le fistula obstetrical tsy vitan'izy efa tsy misafo dia mbola any ambany ravin-kazo any zany izy miteraka. Nefa le olona mandray anazy tsy mahafantatra hoe atreto ty olona ty tokony tsy ho anjarako tsony.
Matetika dia manody lavitra ireo fianakaviana sy ny vehivavy teraka vao tonga eny amin'ny tombo-pahasalamana. Mandra-pahatongeny anefa dia efa tara loatra maty ilay zaza. Ary noho ilay fiterahana sarotra sy tsy ara-pahasalamana dia tratry ny aretina mamany lavana vaky tatavy ihany koa. Maro ireo vehivavy no tsy mahafantatra fa mety hitranga izany ary tsy mahatakatra fa ny aretina mamany lava na vaky tatavy noho ny fahasarotam-pitirahana dia ratra azo tsaboina tsara. Izany indrindra no mazava-dehibe ny fanentanana ifotony mba hisorohana ny aretina sy andresena lahatra ireo vehivavy mila fitsaboana.
Narako moa zany raha Hervelo Jean Charles, technicien accompagnateur ato amin'ny Opération Fistula. Zany hoe mandeha manantona akaikikaiko kokoa an'iregny vehivavy tratran'iregny sy fahasalamana mamany lava regny. Dia mitady an'iregny agny amin'ny toerana izay misy anazy a. Dia rehefa avy mandresy lahatra sy manentana an'zareo hosaboina, ka vonona hosaboina izy ireo a, dia mitondra azy ireo a mankany amin'ny toeram-pisaboana.
Ny tena tanjona aloha mitady mijery an'le mamany lava, le vehivavy mamany lava ao anivon'ny tanàna misy anazy agny zany village. Sy zay nefa sy tonga dia mandehandeha fotsiny le izy, fa misy rindran-damina apetraka hatrany voalohany, zany hoe misy ekipa maromaro zany no miara-misy alahy mikatanteraka an'izay community engagement zay.
Rehefa vita ny fanentanana dia mitondra ireo vehivavy marary azo fitsaboana sy fikarakarana izahay. Izay tapa-kevitra dia mamonjy ny iray amin'ireo obsenteuranay. Rehefa tonga mahazo fanohana anara-tsaina sy ara-piarahamonina hiatrehana ny fivahinanana izay atao izy ireo. Fitsaboana mendrika ny filamatra, tsy latsa-danja amin'izany koa ny hetsika hiarahana amin'ireo marary mba hisian'ny fifampitokisana ary manamafy ny fahatokisa-tena misy amin'izy ireo. Zarina iaina anaty fiarahamonina mahafinaritra ireo vehivavy ireo. Raisin'ny mpiasa ara-tsosialy an-tanana ny marary tonga ao amin'ny obsenteur ary io manana ny zavatra atao toy ny bazary, ny fandrahoana sakafo. Matetika dia tafavory ny rehetra eo am-pikarakarana sakafo, toy izany koa rehefa hisakafo atao amin'ny obsenteur. Ho fanatsarana trano ny lafim-piainan'ireo marary dia mitohy ny asa atao rehefa misy amin'izy ireo miverina manao fitiliana ety amin'ny hôpitaly sy ny obsenteur. Azony atao no mandray anjara feno amin'ireo hetsika fanohana anara-tsaina misy eo anivon'ny obsenteur. Eo ihany koa ireo fotoana anabeazana sy resadresahana anasana ny rehetra eto amin'ny obsenteur.
Aloha hevitra sika androany hoe ino ny vina eritreretinareo atao rehefa mody sitrana avy ny sabo da andeha ody amin'ny fiarahamonina misy anareo agny amin'izay.
Iaho zaho la mody aminay agny aho da agnano vadivarotry.
Agnano vadivarotry.
Magala entana da ino vadivarotry eo. Da zay io dia
ahoana koa raha fieritreretanareo andraisan'ny fiarahamonina nareo rehefa mody agny anareo amin'izao?
Mova io satria mampova anazy ana mbola isen'igny teo zany da tena ndray da olo lalanao da atao sary sy lala. Da mamomba agny olo igny da any karaha sitrany amin'izay anao zany da ndre olo sy mahita anao da akory igny aniveka marô.
Ny avokava tegna io mba mazoto tegna bisoko an-dragnony ao. Mekaiky na afaka me anagny igny.
Ny gesta misy anao mandeha an-dragnony agny ao?
Dia misy mandeha an-dragnony ao aby. Da koragna toa sara be da magnasafa indreo da rapakodakose sara ediboko. Da misangasy da magnety ndray da sisy bozo na sitragny mety.
Silegna raha idobonao ka da?
Silegna raha idoboko sa. Raha eo anagny tanàna sitragny da nahafaky endry koa. Ela zay nampizaly zay. Ito amizay da olo amizay namanareo amizay.
Namanareo amizay.
Velo manareo da moda.
Tsy fanabeazana sy fifampiresahana ihany no atao eto amin'ny obsenteur, fa misy koa ny fivoahana izay atao na eny amin'ny gara na eny amoron-dranomasina, fialamboly mahafinaritra iarahan'ny rehetra atao.
Ny activité sika androany dia efa mahazatra moa zany le ohatran'izao. Rehefa misy marary anay, rehefa afaka soandigny marary dia manao ohatran'izao foana anay zany mitondra marary, mandeha misangasangana kely mba miaraka mifalifaly kely mizoso ivelan'ny hôpitaly zany fa sy mivanona foana amin'ny hôpitaly mandrapodiny zareo dia mba hoe misy souvenir kely mipetraka zany après any aoriana any.